know from a number of trials that have gotten these different agents, these PSMA agents, whether it be scans such as Polarify or Posluma or Illucelix, scans of that nature, gallium PSM imaging, that they're not 100%, that these scans are the sensitivity and specificities. The sensitivities are like in the 40 to 50% range. The specificities are a lot higher. And we know that when you get a positive scan, are you always taking that, let's say they see maybe a small little note. Let's say you think that this is an intermediate risk patient comes to you, and they get a PSMA scan, and you order it. Now you see a node or two that are a little bit of lighting up. Do you take that at face value? Do you talk to the patient about, hey, maybe, we don't exactly know. Everything looks like this might be a localized disease, but maybe it's not. How do you talk to the patient about those kinds of results?
That's with every PET scan, right? Not just PSMA. I mean, they light up in places that don't have CT correlates, or they don't necessarily make sense. There's a lymph node that is very peripheral and it doesn't have anything leading to it. It's always tough because that's the difference between localized disease and metastatic disease. You biopsy it if you can. If there's not a CT correlate, a lot of times I will just watch it and treat it as localized disease.
It can be challenging for the patients too.
It can, because it kind of haunts them with this little spot, no matter what you say to them. But that's with every PET scan. You just have to be careful.
Yeah, and we know that, especially in nodes, that there's, at least with these PSMA scans, there's about a 25% or so chance that it could be a false negative on these scans if they light up. So Jose, we've had some patients over the years.
So yeah, I think you compile, the evidence almost like a good detective, right? So you want to get a piece of evidence, and some of that is just the PSA velocity, right? If you have a PSA of 100, then that's more likely to be a true MET, right? You got a Gleason score of, 7, maybe not. If you got a Gleason score of 10, that increases the risk of the metastases. And then you correlate it, like Scott said, with other information, whether it's a biopsy, an MRI. You can get conventional imaging at that point. Does that spot correlate with something on a bone scan? You go back to older technologies and kind of build your case and see if things make sense in that way. And so that way you can reassure the patient that you're not over-treating or that you're not under-treating that particular case. And so I think that's important. And it's also, working as a team. I think that's the other important thing, is that you have one set of eyes, medical oncologist, you confer with your radiation oncologist, with radiology folks, and then together you guys say, okay, this makes sense, this is our consensus, and then you can even go broader beyond that and look at, at a tumor board. And I think all those things will make sure that the patient gets the exact right treatment.
Gotcha. Kat, just a question. Do you guys, and this is for Scott too, in your practice, are you using ctDNA or anything else, whether it in the early stage or in later stage? I know it's...
Yeah, so, I haven't really used ctDNA much in prostate cancer. I think sometimes you really have to be careful also with these technologies. I think the ctDNA is a very powerful prognostic tool, but I think our tools are sort of outpacing our knowledge of how to use them. So, you may have in an early stage prostate cancer, you're going to have a positive MRD. If it goes up, I don't really know the space in which you'd use that in terms of decision making. So if I don't necessarily know how to use the information, I'm careful at using it. So, so in that setting where it's early stage, for example, I would still go by PSA velocity monitoring of that.
you guys are in Santa Fe, so you have certainly a lot of, how can I say, a high, there's a lot of the patients that maybe come to you are, maybe they're just visiting, maybe this is a second home for them. They may push you to be doing all kinds of alternative and other therapies.
We use a lot of crystals.
A lot of crystals.
I'm sorry.
I was going to add to that. You know, the way I tell my patients is that you already have a very, very reliable biomarker, which is, you know, a PSA, and it costs $20 to get that test, and you can get it essentially every week if you wanted to, without much pushback from insurance. And you know, we have studies that tell us, you know, what is prognostic in terms of a very low PSA, whether it's 0.2 or 0.5 or 2, you know, and so we know what to do with that information. With the ctDNA, you're really looking at new technology that there's no studies out there. You don't know if that, you know, millimolar fraction of DNA actually means anything. Does it change management? So I think that, you know, that's what I tend to tell the non-crystal people from Santa Fe.
Right.
Pretty much everybody at diagnosis gets germline testing with us. If it's metastatic, then they'll get molecular testing on the tumor right away. The hard part is some of these guys, you know, their prostate biopsy was 12 years ago. And then when they develop castration-resistant disease, you're stuck with a liquid biopsy. And then, you know, sometimes you get circulating tumor DNA that has kind of wonky mutations, and you're not quite sure how to follow that. I think circulating tumor DNA levels are important. I think to some degree they're prognostic, but I'm not entirely sure I can affect them. And then you're kind of telling a patient, well, this is a bad sign and I'm not sure I can fix it, which is just kind of a weird conversation, right?
Yeah, and I think he makes a great point is that, you know, sometimes when you do get ctDNA, that you're actually looking for evolution of that clone.
Yeah.
And so, you know, that could be important, you know, when you're trying to find that something that is, you know, changed, whether it's a BRCA or some other mutation that you may be able to target, you know, is definitely important. But in terms of just tumor volume, that may not be the best test to follow disease progression and stability of disease even.